I'm seeing all of you walking in, well, virtually. You're floating in, and it's great to have you here. In case we had an unsuspected visitor just a moment ago when we were huddling to do this, and it was a person who just had come from the Ethernet and had landed in the room and had nothing to do with this. So it was kind of funny. So we're making sure that you all know that you are in the 8th edition, I think, Kelly, of the HIV in Motion Community of Practice. And we have some wonderful stuff in store for you. But most importantly, we have amazing women who have come to present on research that's related to the theme of today, which is women and women living with HIV and exercise. So without further ado, let me see if I can do this. This is the name of our session today, just so you know you're in the right place. And I want to start by acknowledging the indigenous land in which I'm a very grateful settler. I know some of you are in other parts of Canada, other parts of the Great Turtle Island as indigenous people name the entire vast land of Canada. It's important for us to mention this because we want to be participants in the process of retribution, reparation, and reconciliation that is going on in this country. It's particularly important at a time that historically we're thinking a great deal about colonization. And so we invite you to join us in this sentiment with us. So thank you again for being here. Today we have an amazing keynote speaker that has fairly interesting new stuff that was uncovered by their research, and also a quick research update with Kelly, which in this case is going to be an interesting different thing. Our participants later will be joined by Dr. Mona Lutfi, and she's a senior director of Women and HIV Research Program. We are already online with a wonderful dancer, Shelly Tonyasini. I have to say, Shelly, that I have to see you dance. I've only seen photos and videos. So I'm still, you know, I still have to witness it in person. And you and Naomi Maldonado Rodriguez and Dr. Eli Putterman, who couldn't be here today, but Naomi and Shelly are here. They're going to tell us a little bit more about the program as they participate in our panel. So welcome. And this is part of they brought some slides to show us what they're doing as well. But here we go. The first guest, our keynote speaker, is Nora Sahel-Gozin. She is a 2022 graduate from the Institute of Health Policy Management and Evaluation at the University of Toronto. We love big titles for our units, so that's a long title. And she's interviewed a number of HIV positive women about exercise and their experience. And you'll hear more of the nuance in a moment. To tell you that Kelly and myself have worked with Nora now for a number of years, at least 3 or more years, and we're thrilled to see emergent researchers, right? And so we're hoping we do it with the double intention of keeping Nora in the fold, and so she becomes, you know, a researcher and enjoys that lifestyle. Okay, folks, and last not least, you know, Kelly O'Brien is going to tell us a little bit about the new website. And there's one actually fairly new research updates, which I'm going to steal the thunder and going to give you right away. So Kelly and all of you and myself are involved in a number of studies regarding physical, cognitive rehabilitation of people with HIV, and by that we mean things that help us live the day to day. So it turns out that yesterday, one of our granting institutes in Canada, actually the largest one, approved a new grant on chronic pain and HIV. So we're thrilled that we'll be able to start that work, but overlaps really nicely with the works that we're doing. We're really thrilled. Those of you who've written those pesky grants know that it takes a lot of effort and time, and we hate them and we hate each other. So when we finally, it comes up, we're like, oh my God. And we think, oh, that was so easy. Anyway, that's just to start on an excellent note. We're going to move on now to the key presentation, the keynote presentation. And I do that by very elegantly looking in my screen and presenting this to you without panicking, right? Here we go. Enjoy.
Hi everyone, my name is Nora Sahel-Gozin, and today I'm here to speak about my study. The title of my study is a qualitative study exploring experiences engaging in exercise from the perspectives of women living with HIV. And I am a 2022 graduate from the University of Toronto's Institute of Health Policy, Management and Evaluation. And again, I'm very grateful to be here today. Systematic reviews reveal that exercise can lead to specific benefits, including improvements in body composition, muscular strength, functional capacity, cognitive function, depression, anxiety, and overall quality of life. However, despite the many benefits of exercise, a considerable number of people living with HIV are physically inactive and often lead sedentary lifestyles. For instance, a systematic review indicates that only 51% of individuals living with HIV are meeting the physical activity guidelines. And several physical, social, and personal barriers can exist that can prevent people living with HIV from achieving their physical activity guidelines. Within Canada, the prevalence of HIV has risen over the past few decades, with nearly a quarter of all cases being accounted for by women, and a majority of these cases are affecting women who are Indigenous, Black, African, or Caribbean. And so the research question of my study is, what are the experiences engaging in exercise from the perspectives of women living with HIV? And there are 4 specific objectives that my study tackled. The first one is to understand the nature and extent women living with HIV engage in exercise, then to understand the components that characterize experiences with exercise, followed by identifying the facilitators and barriers to engaging in exercise, and finally to identify strategies for facilitating uptake and sustainability of exercise, and these are all from the perspectives of women living with HIV. I recruited women living with HIV who were 18 years and older from Toronto who may or may not have engaged in exercise. I included women who were fluent in English and willing to partake in an interview and demographic questionnaire, and who had access to an electronic device. In total, 16 women reached out, of which 10 were eligible and agreed to participate in the study. Out of the 10 women, however, only 9 participated in the demographic questionnaire, and 8 out of the 10 participants had their webcam turned on at some point during the interview, whereas 2 women declined to have their webcam turned on. And so I conducted online semi-structured interviews using Zoom. All interviews were audio recorded using 2 separate audio recorders and later transcribed. I used also a semi-structured interview guide to ask a series of questions followed by probing questions, including the nature and extent of engaging in exercise, the various components that characterize their experiences with exercise, various facilitators and barriers to engaging in exercise, and finally to understand their strategies and recommendations for facilitating the uptake and sustainability of exercise. Then after the interview, I administered a demographic questionnaire through a web-based platform called Qualtrics, and this questionnaire included 22 items pertaining to personal demographic, HIV and health characteristics, and exercise characteristics. The median age of the participants was 53.5 years. Majority of the participants identified as Black and/or African, followed by White, Indigenous, and South Asian. Most participants were single and had children. The highest level of education was completion of university, and the most common main source of income was the Ontario Disability Support Program. The median year of HIV diagnosis was 1999, and all 9 participants who completed the demographic questionnaire were taking antiretroviral medication and had an undetectable viral load. Finally, 8 participants were living with other concurrent health conditions, and 6 participants perceived their exercise status as good. 5 participants self-identified as exercisers on the self-reported demographic questionnaire, and 4 as non-exerciser. And based on the interview data, 7 women were classified as non-exerciser and 3 as exerciser. The most common type of exercise activity performed in the past week was walking. Frequency of exercise ranged from women who had not exercised in over 5 years to women who exercised every day of the week. Finally, the duration of time the women exercised ranged from no exercise to a maximum of 7 or more hours a week. 6 components emerged that intersected with each other collectively to characterize the women's experiences with exercise, including gender, culture, HIV-related stigma, episodic nature of HIV, sense of belonging, and perceptions of exercise. These components accounted for the variability in exercise engagement with women living with HIV. The first component is culture. Culture was defined by women as one's attitudes, values, and beliefs influencing their day-to-day choices and influences on exercise. Cultural factors were comprised of cultural expectations, intersectionality of women in their social norms, exposure to exercise, and food diversity. Secondly, gender was expressed across all study participants in characterizing their experiences with exercise. Identifying as a woman affected the ways in which they viewed exercise and engaged with exercise. Gender was comprised of caregiving roles and competing priorities, objectification of women, and social norms that set expectations for women. The third component is HIV-related stigma. Stigma, defined as the negative beliefs and attitudes about people living with HIV, influence individuals' decisions to engage in exercise. HIV-related stigma was characterized as both a barrier and motivator to exercise. For some women, issues related to stigma generated fears, which resulted in HIV-related stigma as a barrier to exercise, whereas for one woman, it resulted in HIV-related motivators to exercise as a way to relieve her frustration. The fourth component is episodic nature of HIV. Women living with HIV revealed that they experienced episodic disability. Living with HIV was viewed as having its own set of consequences related to its symptoms and treatments that occasionally resulted in difficulties when trying to engage in exercise. A majority of the women revealed that in addition to living with HIV, they were living with other concurrent health conditions, which further contributed to their episodic disability. The fifth component is having a sense of belonging. Having a sense of belonging within the HIV community, or lack thereof, could either encourage or deter women from engaging in exercise. The component of belongingness was comprised of a lack of community that discouraged women to exercise, a racial divide within certain spaces, and having a support network that garnered motivation to exercise. And finally, the sixth component is the perceptions of exercise. Each participant had different perceptions of exercise, which influenced the role it played within their life. The component of perceptions of exercise was comprised of exercise as a priority, where exercise was seen as either a priority for some participants and not by others. Exercise as a health promotion was also a common view held by all women regardless of their exercise status. And terminology revealed that the majority of women had variable perceptions on the distinction between exercise and physical activity. A number of women also considered themselves as exercisers, even though they did not meet the CSCP guidelines. But all participants stated that knowing the difference between the two terms may promote exercise engagement for women living with HIV. Following the third objective, which is to identify the facilitators and barriers to exercise, we see that women identified several facilitators to exercise. First one is aspirations to achieve a healthy lifestyle, using exercise as a mental diversion from stressors in life, having an exercise companion, and receiving financial support from various community-based organizations. Conversely, barriers to exercise were identified as having limited resources, such as a lack of mental health support in fitness classes, having financial limitations, time and gym restrictions, and finally, the cold winter weather conditions. And finally, the fourth objective was to identify the various strategies for engaging in exercise. Women identified several strategies and recommendations for facilitating the uptake of exercise. The first recommendation identified by women was creating social interactions. This is in order to garner a supportive and encouraging atmosphere to encourage women to exercise. This may be done through various group-based exercise classes or by encouraging women to find an exercise buddy. Women also identified that having online exercise classes would help in the uptake of encouraging women to exercise. This is due to flexibility in their schedule and providing more convenience to women who lead more unconventional lifestyles or have various caretaking roles or other competing priorities, and also allows women to take control of their own workout schedule. Thirdly, women recommended raising awareness on the benefits of exercise. Promoting the uptake of exercise through various educational resources, such as having your family doctor providing you with different educational pamphlets or discussing the different benefits of exercise and how to uptake exercise, was deemed as very important by the women who I interviewed. Discussing the benefits of exercise, even during exercise classes or different seminars hosted by various community-based organizations, was seen as a very helpful tool to encourage women to exercise. And finally, offering practical support was seen as another recommendation brought up by women. Practical support can include having different childcare centers or providing financial support from various community-based organizations. I will provide all the references I use in this presentation using a clickable PDF. I would first like to thank the various organizations where I recruited the women from. This includes the Casey House, ACT, and the Maple Leaf Medical Clinic. I would also like to thank my mentors and supervisors, and this includes Dr. Kelly O'Brien and Dr. Mona Lotfi. And I would like to thank all of you for watching this presentation today.
So Nora, how are you feeling about your work?
Thank you, everyone, for listening to my presentation and bearing through that. It's been going very well. I didn't mention in my presentation, but I just wrapped up data collection and analysis just a few months ago. So we're in the research dissemination phase. So everything went well in terms of data collecting, and I had a lot of fun as an interviewer and as a researcher on the other end. So I'm happy to answer any questions or comments that folks may have about the presentation or the work that I've been doing for the past year.
Thank you. Yes, and we remind folks that they can join the questions. I mean, they can add their questions to the chat room anytime. Kiera and Kelly and myself will be paying attention to that, and we'll get to that in a moment. We have a short presentation from the folks from Positively Dance. But Nora, two things. One is you struggled with the elements because at the moment we were doing that recording, there was a drilling going on above your head. So when people heard that it was the drilling. So that must have made you very nervous. So thank you for going through that.
It wouldn't stop, but Francisco insisted that the show must go on. So we continued.
And the second, I'm just curious, very quickly, why did you make the particular remark that some women turn their cams on and some didn't? I'm just curious in terms of doing research online.
So we had 2 women out of the 10 that we interviewed that declined to have their webcam turned on due to privacy reasons. Traditionally, they were used to having one-on-one in-person interviews. They felt more comfortable. You're able to read body language more, carefully, and you can create somewhat of a more closer relationship, I find, with the interviewer and interviewee had it been in person. So unfortunately, because everything was virtual, we kind of had that disconnect in a way. But we tried before the interview just to talk and answer any questions that they may have before the interview and demographic questionnaire. But largely because the pandemic was still sort of new, or it was at its peak when we were doing the interviews, some women didn't feel comfortable to have their webcam turned on, or perhaps they were living with other people in their homes. I mean, it could have been an array of reasons. So for that, we respected their concerns, and regardless of not being able to read, nonverbal communication, they still answered all our questions, and they were very open to everything. So regardless, we're really grateful for that.
That's wonderful. We're grateful to you because you soldiered on, so to speak, through the pandemic, and you and, of course, and Mona and Kelly just got this done, which is amazing. So, folks, before we enter the full panel, I'm going to introduce Kelly. Please let me know when Mona's here. I don't want to ignore her if she's coming to the room, but we're going to introduce the folks from Positively Dance. So Shelly Tognasini, and she'll tell us more about her background and what she does. And Naomi Maldonado Rodriguez, you see I can pronounce this well because it's in my mother tongue, will tell us a little bit of what they do, and from then on we'll move on to the panel. So keep on thinking about your questions or comments and let us know, put them in the chat room and we'll pay attention to them. Naomi, we're ready for you folks. Thank you.
Wonderful. Can you see?
All is good.
Great.
Okay, perfect. Well, good morning, everyone. Thank you all for joining us this morning. My name is Shelly, and my colleague is Naomi. And we're going to be, today we're zooming in from the unceded territories of the Musqueam, the Tsleil-Waututh, and the Squamish nations from the city known as Vancouver. Today we're going to give you a very brief overview of the making of the Positively Dance program. So how did this all begin? Well, the original idea came out of a community focus group associated with the CIHRRC project, the Canadian HIV Women's Sexual and Reproductive Health Study cohort study, which some of you here today, Mona, if she's here, of course, was intimately involved as a principal investigator. And during community-led conversations and focus groups here in Vancouver, women were asked what interested them in terms of women's programming, in terms of exercise, and women expressed a strong interest in something other than a support group opportunity, and dance classes resoundingly were mentioned. So from that, Dr. Helene Cote at UBC did some community networking, as she does so very well, and she introduced myself to Dr. Eli Puderman, who unfortunately couldn't join us today, but along with Dr. Erica Bennett and Dr. Mark Beauchamp. And we formed a community advisory board and began what was an extremely adaptive approach to building a feasibility study for a peer-led dance program, the bulk of which was created during the pandemic.
And what we initially planned was a pilot randomized control trial that would evaluate the feasibility of a 3-month peer-led dance program. And to facilitate the dance instructor component of our study, we had hired, or we were planning to work with a US-based dance company that would, roll out this dance instructor training. And the planning was going very well until the pandemic.
As we all know, there was enormous limitations and restrictions during the pandemic, but there were also amazing opportunities for reinvention and thinking outside the box, or in this case, the dance space, as it were. And the biggest impact that we felt in British Columbia was that dance and fitness studios were one of the most consistently restrictive spaces. And of course, that created all sorts of challenges. We tossed between waiting for the restrictions to lift, virtual training versus in-person training, and we eventually ended up with a combination approach that could adapt to dancing during the pandemic.
As I mentioned, we were supposed to partner with a US-based dance company. However, because of the pandemic, traveling cross borders was no longer possible, and so we had to adapt to that. And so around this time, we began looking for new potential partnerships with dance instructors, and we happened to meet this lovely Indigenous woman called Angela Gladue, who also connected us to her dance crew partner, Sherelle. Both of them specialize in hip hop, soca, powwow, respectively. So they designed the Grooveman dance program, which is what we rolled out to our dance instructors who are now currently teaching. We promoted for this dance instructor position through local community organizations, word of mouth, as well as women's support groups. And of the 6 women who applied, 3 were hired. However, only 2 finished the dance instructor program, and those 2 are now delivering dance classes through our program.
So how's it going now? Right now, we launched as of June 15th. We have not missed a single class, except for one for Pride Parade due to the transportation logistics and wanting to honor our Pride brothers and sisters that were participating. So classes are on Wednesdays at 4 p.m. and Sundays at 1 p.m. And currently over the summer, our attendance has ranged from 3 to 6 per class. However, we do expect our attendance to increase dramatically, hopefully double in the fall.
So what kind of feedback and lessons have we learned over the course of the last 3 months? So first of all, the importance of affinity spaces. So we have a space that's specifically for women living with HIV. So while we haven't done exit interviews yet, we have received casual or informal feedback saying that it's been really important for women living with HIV to have a space to gather in community, which is specifically for them, an affinity space. And relatedly, the importance of this space being non-identifying and non-stigmatizing. And so the beautiful thing about these dance classes is that when they enter the dance studio, it's not immediately a space that identifies them as women living with HIV, but they still get to, be in community, but without the risk of that stigma following them. And then lastly, the value of a peer coordinator and mentor. So Shelley is our peer research associate coordinator, mentor. She doesn't teach dance classes, but she provides valuable support to the dance instructors and also sometimes subs, as she has a background as a professional dancer, a former professional dancer. And she contributes to all aspects of the project, the research, the community engagement, the teacher training, and it's been absolutely essential. I can't overemphasize, I can't understate how grateful we are for having Shelley on the team.
Naomi, thank you. So what we've also learned is that word of mouth is absolutely key, and it's really our biggest promotion tool. Women telling other women that they went to class, that they liked it, or they didn't like it, but for the most part, they've really loved it, and encouraging their pause sisters to go with them. So it's kind of I told a friend and I brought a friend. And so this word of mouth thing has really been building. We also learned that the barriers intrinsic in a rigid methodology, such as a randomized trial approach, was simply creating barriers. And so we decided recently in the last month to remove the randomization and added ongoing enrollment. As well, we've learned to think much bigger in terms of attendance and patience. In the old adage, build it and they will come. And I believe that we will see the results of that specifically over the next few weeks, with several women now joining us that summer's ended.
So what's next? We have officially decided to extend our program until March 2023. So it was initially supposed to end in the mid-December. So now we'll be extending a few more months. We're also moving towards a drop-in format. So prior to this, we were asking women to commit to twice a week for 12 weeks. And we were finding that to be a barrier in terms of, it's a lot to ask to commit 3 months of your life and be committed to something that you haven't even tried. So now we want to be a little bit more flexible and allow more of a drop-in format. And then lastly, we will also be moving into our interviews to get feedback and advice from women, and also learn about their experiences partaking in the dance program and about what this program might look like in the future.
So these are the questions that we're considering now as we evolve. How do we transition from a research setting to a community-run program? What does scaling up look like? And how do we build in opportunity for ongoing training and support for our current and future dance instructors? And what practices do we have in place to prioritize diversity, equity, and inclusion within the program? These are the questions we're asking, and we welcome your feedback around these questions and what the future of this program may look like, not just in Vancouver, but across the country.
Lastly, a heartfelt thank you to everyone involved in the program, and to listeners. Thank you for learning about the program. We look forward to talking about it with you.
Thank you all.
Thank you. Another round of applause. I hope I'm not muted this time. So, thank you, because clearly we'll invite you back because there's a lot more to say about this. Before we go into the panel, I must remind you that we're going to ask you several times that at the end, and then when we send the thank you for being here, that you evaluate us, because that's how we make the big bucks. No, that's not true. We have commitments, and we have to say how we're doing it. It also helps us, change things when they don't work very well. So, I will now, actually, Shelley, let me start with you while people formulate their own questions, and that can be verbal. You're welcome to unmute and all of that. Shelley, you and I have done some learning together, and you've been preparing yourself for this for a long time. I don't mean to say that this is the apex of your career, so to speak, of your being, but what's been the other than the things that you showed us in the slides, what's been the significance for you after all this long road? You've been doing this for a while. Prior to my life living with HIV, my life was living in dance, in modern dance specifically. So my background was Graham. I studied at Toronto Dance Theatre at the Graham School in New York and did a BA in dance. And I actually, when I got diagnosed, I didn't feel the impulse to dance anymore. I felt that I had kind of had to leave that life behind me. Ironically, I had danced for Dancers for Life in the 80s for Andrew Highway and other men that we lost. The dance community was devastated by the pandemic in the 80s, as some of you will remember. And specifically in the ballet and modern world, dancers were dropping like flies. And so we were doing a lot of, at that time, I was completely ignorant. And so as I've aged, gracefully, I hope, I have learned the value of dance and that every body can dance. It's not contingent on what I was raised in the 70s and 80s, where you had to have a certain body type, you had to be a certain height, and that's simply not the case anymore. So as I evolved, I've come back to a place where dance is something that I really feel honored to be able to share with people. And I also, Francisco, to your question, I mean, I remember meeting you with
University Without Walls. And I think that was the first, I'd never done a presentation. And so I found my voice actually by learning how to make presentations. So yeah, that goes back almost a decade, I think, close 2020 or 2013, 14, something like that.
We were in our 20s. I recall that.
Yeah, absolutely. Yes, that's true. Yeah.
It's clearly.
Yes.
Thank you. I'm so glad. Actually, on that kind of historical note, those of you around the virtual table should know that there was a wonderful organization by the name of Positive Women's Network, and it folded, which we were all very sad. So has this, what you're doing, Nora and Shelley and Dr. Putterman, doesn't come to replace that, but it adds to the loss. Is that your view?
Absolutely. I mean, and Naomi actually has an extensive background in dance as well. So we've been very fortunate that we have a research associate that as well has a background. So we've had, people around the table that have either been dancers or took dance classes, understood what it took. And, like Naomi was very complimentary to me, I have to also return the compliment in that it really helps when you have people on your team that understand not just the benefits of a particular exercise program, but the benefits specifically of one type of exercise program. And in this case of dance, because we really tried to really make it diversely inclusive, we've had, just such amazing women that have come in and, that they'll say it's really hard to get here, but once I'm here, I'm so glad I came. And the resounding effect is that even if it's tough to get there, once they're there, we have fun. Aside from all that, we have fun. We get 15 minutes post-class to sort of debrief and share, and we have a little community check-in. And then sometimes we walk up Granville Street and listen to music, and sometimes we walk to the park. So it's been really, really beneficial to building community, a space for women to go. The lack of Positive Women has definitely impacted our local community in a massive way.
For sure. And thank you, Shelley. Nora, how does this all kind of resonate with your experience as a researcher and the data that you collected, the analysis that you made? How does this resonate with you?
Well, the factor behind why I did the research that I did was because there was such a gap in existing literature and on women's experiences with HIV. So I discussed this as well in my thesis and my own research of how there are research exercises on people living with HIV. However, there's a lack in women living with HIV and their experiences with exercise, whether that be, their barriers or their facilitators, different cultural expectations, social expectations they may have. These components were lacking in research. So in terms of what I'm adding to the community, I hope that I'm kind of filling in that gap of women living with HIV and exercise and how we can create more of a self-management strategy for women. So what Shelley is discussing is amazing. There's community events, exercise programs, maybe dance classes, but also to allow women to take control and maybe do exercise in their own free time, in their own safe space. So also looking at exercise as a self-management strategy, I think is really important too, for perhaps women that maybe are not comfortable with going into group spaces. So I think exploring all these components is really important just because, again, there's a lack of information. So I think we're all adding, whether it's a little bit or a lot to the community. So that's how I feel about that.
Yeah, it's taking, I mean, as a person with HIV for over 3 decades, it's taking too long for us and to actually start all this kind of research, right, on women, transgender women living with HIV. So, but Nora, I wanted to ask you, there's a question in the chat room that I cannot recall. Someone will help me remember it. But okay, Nora, here's a difficult question. So remind us again, what does CSEP stand for? What are those guidelines? Why did you use them?
So that's the Canadian Society of Exercise Physiology. These are the guidelines. And they've actually recently updated their guidelines. So they're just the physical activity guidelines that people, adults 18 to 64, are recommended to follow. So that's 150 minutes of moderate to vigorous aerobic physical activity each week. And that's different depending on your age range. So if you're a child or a senior, that will fluctuate. However, in 2021, I believe, right near the end of 2021, the CSCP updated their guidelines. So now it includes also sleep behavior. So having 8 hours of sleep is really important, sleep hygiene, and also limiting sedentary behavior. So those were two components that were added to the guidelines. Whereas when I was conducting my research, it was strictly 150 minutes of exercise each week or physical activity. But now they've updated it to also include limiting sedentary behavior and sleep, which is really nice because one of the difficulties that I had when doing my analysis, which I kind of came to realize after conducting my research, unfortunately, data collection, was that while the CSCP guidelines are for adults 18 to 64, it doesn't take in consideration people that are living with chronic conditions. So had there been maybe more subcategories or maybe more specific, guidelines for people that are living with maybe comorbidities or people that have disabilities or, these things were not accounted for, unfortunately. It was more like a generalization. So going forward, I think maybe kind of looking at that in future research and seeing how, if that's an appropriate guideline to set for folks that are living with chronic conditions, if that's appropriate or not. So that's something, unfortunately, I came to realize during my analysis. So that was something that I didn't even think about beforehand, but it came up during my write-up of my thesis.
Right, and that's what analysis is for, right? It helps you figure out, okay, this is what there needs to be done in the future. Is this what you're going to do in your PhD?
Oh, we're jumping way ahead, aren't we?
I like Kelly's. It was all designed to see Kelly's expression.
Yeah.
Do not pressure your students. No, you don't have to answer that. But as you mentioned that the CSEP guidelines, right, which you took very seriously to kind of do your analysis and the interviews, they don't consider chronic and episodic. Do they consider gender? Are they the same for transgender persons, from cis men, from cis women?
That's another interesting point. No, it's strictly just adults 18 to 64. There are other existing guidelines out there, like the World Health Organization. There's a plethora of guidelines out there that do take in consideration more of these aspects of chronic conditions, people living with, like, say, diabetes. But unfortunately, the CSCP guidelines is more just generalizing based on just age. But unfortunately, gender was not a component that at least I came across whatsoever. But I would be interested to see how that would categorize individuals differently as exerciser or non-exerciser had there been more specific guidelines for people.
For sure. That's for your postdoc. Oh, Kelly, don't kill me. I'm already at the postdoc. Okay, sorry. Thank you, Naomi. Let me get back to you and tell us a little bit more about your experience working with women living with HIV. Is this something you had done before? Was this kind of new for you? I mean, I'm sure you worked with women and women dancers, but what was the experience like?
I had not worked with women living with HIV before. I have worked, like, my master's was working with women who experience intimate partner violence. So I guess from the perspective of being aware of the sensitivities and that are involved in engaging with women who are experiencing different systemic barriers, different forms of structural violence, then I did have that experience. I think it's been amazing. Like, I think there's a certain level of, there's always considerations around privacy, and I would say privacy is probably the big consideration, and consent, always talking about consent, how you divulge information, how I engage with women, but I think I approach everything from a perspective of a trauma and violence informed approach, and I like to apply that to everyone. And so it's very important, I think, when you are engaging with women living with HIV, but I think that because I came from that perspective, it's made the transition very smooth for me. And I hope women have have had positive experiences interacting with me. I can't speak for that.
It will. No self-doubt. That's my associate advice. Good for you. But so disclosure is something that called your attention. And of course, all of us as peer researchers, as persons living with HIV in different contexts and different countries and different genders, it's something that is always with us. Naomi, we hate generalizations, but let's generalize. Was there something that you thought, oh, I didn't expect this? This women, and I know we're generalizing out of the group of women you worked with. I'm completely aware of that. But I never expect, oh, so this is what happens with women live with HIV. We have the disclosure. Was there anything else that you thought, oh, I didn't expect this?
I think, to be quite honest, I wasn't surprised, but it's always interesting to see it play out in real life with respect to how people navigate, their disclosures, especially in a group setting, right? So we're bringing people in affinity spaces, but not everybody's comfortable being, publicly identified. And so I think navigating that and navigating the individualities, because this changes from person to person. So being able to navigate that, I think, has been really interesting. Especially because, as the program grows and gets a little bit more of a public facing, like gets more interest from the public, and especially because we roll out our programming from a non-HIV AIDS serving organization. It's based at the Scotiabank Dance Center. And so when we field questions from them asking, like, oh, can we promote your program and stuff, we have to navigate now, like, okay, well, do we want this to be, do we want to call attention to this? What do women want? Like, who wants what, and when it's not unanimous, as it often isn't, then how do you make those decisions? And I mean, often more than not, like as a research team, you're not the one who should be positioning yourself as the authority on this, especially as folks who don't, like, I'm not someone who's living with HIV, so I'm not someone who should be, positioning myself in, with this authority.
Yeah, thank you. And thank you very much, Naomi. And for those of you who have been to Vancouver or live in Vancouver, when Shelley said, and sometimes we walk down Granville Street, is because the Scotia Centre is on Granville, and I forget the other street. I used to work around the corner at Positive Living, BC. So what's that street? Nelson and
Granville and Davie, right on the corner. It's in the old TD Dance Building, and it's a beautiful Ballet BC's home. It's where Ballet BC lives.
Oh, wonderful! So space is very important. Let me go to our audience. Sorry for a second. And Joanne, I see you're there. And how's it going today?
Very good.
I know. I so good. I know you're a woman of a lot of experience, and you've had the chance to, over the years, to think about it, in particular in the without divulging too much, in the particular kind of last year, you've had the chance to think even more about exercise and living with HIV. Tell us a little bit about that, please.
Well, I want to start out by thanking Nora so much for your research, because really there is very little research done in Canada on women, aside from Mona and all of the CIHRRC team. So, and thanks, Shelley, for telling us about this really innovative program. My experience with exercise goes back many years, and I actually was involved in Kelly's pilot study. And I think it was like 2014 or so, if not even before then. So I have had a long-standing interest and experience doing exercise at I personally have belonged to a private club. It was easier for me to get to than the YMCA. And I just wanted to talk a little bit about how, because in the past year and a half, I have experienced ovarian cancer, And through chemotherapy, it led me to not really being able to move at all. So what I wanted to point out was how quickly your body deteriorates, even though you have done regular exercise over a number of years. Once you stop moving for, like a month at a time, it's just really, the downhill slide is really quick. So I really feel that it's important to make sure you start from a very high plateau, so that the downhill slide doesn't go so far down. But I mean, I got to a point where I could not even stand up without assistance at some point. And I remember after spending a day at a hospital doing all kinds of tests and being kind of exhausted, getting out of a taxi at the place that I was staying, and literally sinking to the ground because I could not get quickly enough into the wheelchair, and I just fell down. And it was really, it was just shocking to me that I could get to that stage so quickly after being after being fairly active and busy. Although I have to say the pandemic kind of cut off some of my activity before this happened, so that also contributed to my quick downfall. But I just think that exercise is so very important for positive women. So many of them, Nora, you went through many barriers and not so many facilitators. There are many barriers to women participating in regular exercise programs. And I think it's important that we continue to ask women about their experiences with exercising, and do they need help with that, and wherever possible to find ways to help overcome some of the barriers, because there are so many. So thank you so much, Nora, for doing that research. In fact, I think I was supposed to participate in it at one point, but then I started to not be well. So I'm so glad that you were able to proceed. And that's all I have to say right now. Thanks so much, everyone.
That's amazingly it's important for us to hear. How are you doing today? In terms of being able to move and things like that, Joanne?
So my rehabilitation through a cancer survivorship program at Princess Margaret Hospital has included me having access to a physiotherapist, kinesiologist, occupational therapist, and that has really helped me to maintain, some strength. I went to the International AIDS Conference this summer and was a very active participant for like a whole week. So that to me felt like a real accomplishment after some of the shortfalls in stamina that I had experienced over the past 12 months. So I'm doing quite well. I can certainly be stronger, and I'm not anywhere near the level of fitness that I was before this happened. I haven't been doing weight bearing exercises, for example, and that's really important to build up some muscle strength. But I'm getting towards thinking about doing that sometime soon.
Good. And I hope the road ahead, gets easier and you get the stamina and certainly you have the will to continue. You and I have been working together now for many years. So it's good to see, that you've sailed through the storm, so to speak. So we thank you for that. And on that note, in terms of programs that exist, we know that there are fewer and fewer programs for women living with HIV or women living with other specific conditions. I think what happens sometimes in research is we create these programs, but then there is the issue of, are we able to sustain them? And I wanted to go back to Shelley and Naomi, because you actually stole my thunder in one of the final slides of your presentation, and say, well, how do we continue this? Because we don't want to it happens many times in research. We have like wonderful programs, and then the research body goes, and so that's the program. I'm not saying that's a bad thing. It's part of a parcel of this soft money kind of. So what are you thinking could really help you sustain the program? Because it's clear that it needs to continue.
So excellent point, and something that we grappled with very early on and wanted to make sure that we could find a way to sustain this. One of the benefits of this program has been our cost effectiveness. And what we've been able to do is, because the Dance Center is a nonprofit, community-based organization, we get outstanding rates for our rehearsal space, or sorry, for our practice, for the studio space. So number one, that's really important. Number two, because it's peer-led, we are paying the dance teachers. So all of the teachers are HIV positive women that have gone through this training. So it's by HIV positive women for HIV positive women. But we got outside training from Angela and Sherelle because they've offered an expertise, and they designed a program based on the Community Advisory Board's input. So when questions came up like, what do we need this to look like? It didn't come from Naomi and my dancer brains. It came from the community saying, this is what we want, and this is what we think would work best for us. And also to the question of financials, basically the women will never pay for class. So the classes are all free. They get paid for their survey, and I'll let Naomi speak to this a bit, what they are paid for in breakdown, but they were paid originally for introduction survey, which was also an eligibility criteria, and then they got paid for blood draw, and then they get paid for follow-up surveys. And we don't have childcare, but we were not opposed to the idea if we were asked. So far, none of the women have asked. I think they're taking this as their time, that they don't want to bring kids. This is something that the women want to do for themselves, and I think that's really important to acknowledge as well. Naomi, you can speak more to some of those issues. And budget, we were very lucky. We only got a third of our funding. So it's not like we got a ton of money to do this. We didn't, but we managed to make it work on a very limited budget. And I think that's in part due to the generosity of not just the women that attended, that women continue to attend without the expectation of having to be paid to be there. And I think that that's partially one of the most important things that I think women living with HIV need, that empowerment piece as well, that we don't always have to pay them to participate, that sometimes they just need to want to show up and make it work for them. And because it's on the bus line, we've made it as easy as possible, and it's right down the streets from AIDS Vancouver. So if they're going, again, the times that we chose, thank you for that question, Kelly, we chose because they asked for those times. We didn't arbitrarily pick those times. We asked, what would you like? And they said a weekday and a weekend. And so we went with Wednesday, 4 o'clock, and Sunday at 1 o'clock. Naomi?
Yeah, maybe I'll speak to, Shelley spoke to the fact that I think we've been very cost efficient with the way we rolled out this program, which is what's allowing us to extend it a little bit further. We're also like very actively always talking about, how does this get rolled out into the community? How does this exit the research setting? Because it's still the organizational capacity, I'm still the program coordinator for this. So how does this move away from, having its hub, I guess, based in its organizational capacity based in a university, and move into community and move into kind of that self-sustaining area? That's a question that we're constantly grappling with, and it's very much so at the center of the project. And ongoing challenge, I think, but some of the things that we're really prioritizing is, building relationships with well-established community organizations in Vancouver, and looking into having those discussions moving forward. And, part of it is also giving it time, seeing what the interest is for this kind of programming, but also giving it time for that momentum to build up. Programming always takes a long time to be built up. No program starts with, 50 people showing up on a regular basis. It does take time for that to build up. So the way we've managed our research funding is hopefully going to help us have time to build that up, and I guess build a case for why there should be continued funding, and then also help us funnel the organizational capacity elsewhere so that when we step out, this program can also be self-sustaining, right?
I hope so.
And also, I'll just add one more point, that there are
Sure.
foundational funding that we're looking at. So it may not be based in research. We may have to take it to community funding that will support it. And because there is such a demand right now, or a need and a gap, I think that we might, having proven the feasibility of this study, which we will have done in spades by the time this project is done, then we will be able to be in good stead to ask foundations, independent philanthropists, et cetera, within the city of Vancouver to see this happen.
Yeah. Well, keep us in mind, and as collaborators, have your people call our people. Kind of thing. It makes me think, actually, in Toronto, and I'm sure it happens at different scale, different cities. There's a group that does Zumba. It's a group of Latinos positivos, actually, positive Latinos living with HIV. And it's amazing how dance really gathers everyone. Actually, when I went to visit them, this is a couple of years ago, before the pandemic, sorry, one of the things that struck me was like the confidentiality was very confidential. They told me, you got to be very careful with this. Well, I arrived there and there was like the aunt, it was the cousin, my friend came. So I didn't say anything anymore, but people understand it in different ways, right? I mean, Naomi, maybe you can relate a little bit of this from our Latino background. I expected like closed doors. No, there was food. Of course, it was food. The whole point was to do Zumba so we would eat after. So I think those things are important. I really hope that the program can continue. I want to turn my attention now to some of the questions that came up in the chat room, and I hope I'll attach on all of them. But Nora, the first was, for you, someone is intrigued of why you ended up, or how you ended up with 10 women, and there were 30 women interested in participating. How was that?
I just first want to thank Joanne for sharing her story. It was nice to hear firsthand experience, so thank you for that. And to answer the question, so we had 16 women show interest, not 30, of which 10 were brought on and interviewed. Unfortunately, we feel that it was due to the Zoom fatigue, which was brought on by the pandemic. It wasn't necessarily because they didn't meet the inclusion criteria or anything like that. It was strictly, I think, just people were getting tired of being online, virtual. It's a very tiring experience after a while, especially when you interview and do a demographic questionnaire afterwards. You do want to kind of take a bit of a breather. So I do write about this as well in my research, crediting it to the Zoom fatigue. So I'm not sure if anyone else wants to add to that, but yeah, it wasn't anything to do with inclusion criteria, but more so, I think, just because it was a virtual experience. Some women, when it came to actual the interview time, they sort of backed down. And again, who knows what the reasons were, but as researchers, we just assume it's because of the pandemic.
Yeah, that makes sense. Thank you. I want to acknowledge that we've been joined by Dr. Mona Lutfi. Mona, how are you? You look a little bit tired. Happy belated birthday.
Yeah, thank you. I was just saying, oh my goodness, I'm so tired. Do I tell everybody I'm tired, or?
No, but you have your bike there. You have your bike there, which means that you're exercising.
Yeah.
So, Mona, very quickly, I want to invite you into the circle of the conversation and ask you, unfortunately, I don't think you had the chance to see the presentation by Shelley, but, oh, you know about the project. What am I saying? I'm sorry. My mistake. So you've seen these two projects, right? You've seen Nora's result. You've seen what Shelley, Naomi, and Dr. Putterman are doing in BC. For you as a clinician, what difference does that make?
Yeah, so it's interesting. I've been thinking about this, like preparing for this panel, and I know Nora's worked really well since I was on her committee. But I would say, for everybody, like for all humans, in terms of health and longevity, there is nothing more important than exercise and what we eat. And then in the context of HIV, someone living with HIV, I would say that it's even more important. And so I'm late because I'm in clinic. And as an HIV clinician, so often like patients will come see me and we don't have that much time. And all we're concentrating on is, are you taking your antiretroviral therapy? What's your viral load? And like, it's just like such a like narrow myopic view. If some people have seen I make these like nutrition sheets and exercise sheets that I give my patients, but it's like I like squeeze it in 30 seconds at the end of the visit. Like, you should be like eating higher protein, but like more fish, cut out as much red meat, cut out carbs, lots of vegetables, eating, vitamin D, how much calcium you should be getting, and then weight training, like building muscle. It correlates with longevity, yoga, walking, cardio, I do that in 30 seconds, but I wonder whether I should be concentrating more on that than, focusing so much on antiretrovirals and viral load, because actually, nutrition, like that sort of diet, and also the exercising, has been shown to decrease inflammation. So, and then it's inflammation that leads to cardiovascular disease and, other medical conditions that are potentially made more, to progress faster with someone who has HIV. So I just think that, Nora's work and Naomi and Shelley's work, I think it's so important. And I think that this should be a conversation that is had more at a clinical level, and that it's moved up in the discussion when we're seeing patients. If that sort of, I'm kind of jumping in. I hope it kind of fits into what we've all been discussing, but I just think it's so important, and we need to move its priority in our clinical visits.
Completely. And on that note, actually, I want you to dish about your male colleagues. Do you think, this is a gross generalization, we're just talking. Do you think your male colleagues working with women with HIV have the same understanding you do in terms of all the things that you suggested, that you also take this time, rushed as it is at the end? What is your overall sense of your colleagues, but specifically about your male colleagues?
I wouldn't divide it by gender, male colleagues or women colleagues. I hope my internet's okay. I don't know. Sometimes my internet. Okay. What I would divide it as is specialty. So, across Canada, but like particularly mostly in other parts of the world, HIV care is provided by infectious disease specialists. 70% of HIV care is provided by infectious disease specialists. And in Canada, we have actually more family doctors that provide HIV care. And I would say if someone's getting their HIV care or has a family doctor that's really involved in their care, they're practicing from a person-centered care model. It's a primary care model where prevention is a really big part. So as a family doctor, I think diet and exercise is like high up on the discussion list, but I think within.
Oh, and then we have a little bit of a bleep. Oh, sorry, you were bleeped for a second. Go ahead, Mona.
Okay,
sorry.
Yeah, my internet is not fantastic. Sorry, I can't do anything about it. I'm in clinic.
No worries.
So I think the infectious disease specialists are the problem. That they're the ones that are focusing on just the antiretrovirals and HIV viral load. So if we could do some kind of, sometimes many patients only see their HIV doctor. So they will only see that infectious disease specialist. So we really have, I feel we have to target infectious disease specialists, that they have to provide a more holistic care.
Right. Yeah. And actually on that note, Nora, I want to get back to you and ask you whether you noticed, this is not about me, but I noticed that as I've grown, I'm almost 60, there's less and less interest in what I do. It's just like, do you take your pills or not? Right. And nobody gives you a dime for like half an applause for keeping in shape, for having activities. Kind of, it's part of aging, right? You become invisible, and it's like, did you take your pills? Did you get, Nora, the sense from your the group of women you worked with, because there were different ages, right? Did you get the sense that they became more invisible in that respect in terms of exercise? What sense did you get?
So the median age of the women, most of the women that I interviewed, they were over the age of 40, so between 40 and 60. So they were a little bit older, and they had their own, they had their own way of looking at exercise. And most of them had been living, actually all of them had been living with HIV for at least a decade. So they've been living with HIV for quite a while, and they're older women. They have different set of responsibilities than, say, a younger woman who's in her 20s or 30s, who's having, children, and sort of that, the things that come with being a little bit younger. So with them, when I interviewed the women, it was more to do with positive reinforcement. So if they saw, say, a change in their bodies, or if they saw that, oh, exercise is making me, feel better, look better, then it was a sort of a positive reinforcement for them to continue to exercise. And that's why in the batch of women that I interviewed, only 3 of them, by our definition, were classified as exercisers. And when we look at the reasonings behind why and why they were classified as that, it really came down to their perceptions of exercise and their attitude towards exercise. All women, regardless of their exercise status, believe that it helps in every aspect of their life, both mental health and physical health. But whether they actually integrate that into their day-to-day activity was very different. And we noticed that women that were constantly exercising, given that that's sort of their general outlook, it really boiled down to sort of that general, positive reinforcement. So they saw these improvements. And aging with HIV is also another issue, because, a lot of the women, when I spoke with them, they would tell me there's not a lot of research out there on myself, right? It's a lot of men living with HIV, and this, this condition that they're living with, they're aging with it as research is going on as well. So it's not something that's been researched for, decades or, centuries or whatever. So they knew that with exercise, it would help them with the aging process and the episodic nature of HIV itself. But I thought that as an interviewer, when looking at the data, it really came down to, was there the sense of positive reinforcement in their exercise? Was there consistency? And that made them want to exercise more. Whereas for women, especially those living with other conditions like COPD, asthma, diabetes, who maybe had previously done, alcohol abuse or drug abuse, they were living with other health conditions. They were at more of a halt in how much they wanted to exercise, or they could exercise. And living with lipodystrophy, it was really important for the women to do muscle strengthening exercises. So naturally, as you get older, Mona can talk about this too, you are, it's more fragile, it's a bit more challenging to exercise. So some of the women that were just beginning to exercise in the later stages of their life found it much more difficult than the women who had been doing it previously, building on that. So I think it just depends on what your baseline is and what you started out with. All of these aspects come into play to dictate whether a woman really wants to continue to exercise or not. So there's so many different factors to kind of look at when answering that question.
Let me thank you. Let me ask you all a provocative question that stems somehow from this. You'll see the connection, or imagine it. So, it is my sense, which is a very narrow view, very limited, that women living with HIV are better off on their own than when they have families and lovers, which is not always works well, than that they have to take care of because of the gender role, right? Like, you're a woman, you need to do this. It's a provocative question. Let's start with you, Shelley, and then we'll go to Mona and Nora and Naomi. Are women living with HIV better off when they're on their own in terms of doing these things for themselves, right?
Okay, so I was a single mother of 2 girls, 11 months apart. I'm now a grandmother. And I was a dancer before, this is prior to HIV, but even as a woman, an aging woman living with HIV, and also having had that headset of everything that I did in my day, I had to account for every moment, and I had to make sure I had my grandmother, the grandmothers in place, or the aunties, or the family, the village mentality of what it takes to be a single parent. You have to have some of that, but I would also say, I'll just add, that's a really loaded question, but I would say that women, as we age, I think are seeking community more and more. I think the younger we are, the less involved we might want to be, whether that's because we don't want to be out with our status, whether we don't want the stigma. But I believe as we age with HIV, we get a little bit more settled in our bodies and understand that this is part of me. It's not all of me, it doesn't define me, but this is part of what I live with, no different than someone living with or recovering from cancer, Joanne, or someone living with comorbidities, or someone living with, as I do, with COPD and a heart issue. I have learned that, I think, wrap it up real quick, I think that dance provides an opportunity, because even though it's a patriarchal dominated world, let's face facts, it is habited by women, and women love to dance. Overall, I would say that's a gross generalization as well, but dance is the common denominator that brings us together, not HIV. And so I think when we look for exercise common denominators, that's what we're looking for, and dance provides that culturally, and just on multiple levels. So I think that's the gold card, is that can we participate in an exercise activity that we love, that we want to be a part of, and that we're not judging our bodies for. And that comes with maturity. That's not necessarily a 20-something ideology.
No, it makes sense. Let me go back to you, Mona, and sort of running on what Shelley has said, and my original very brutal kind of biased questions. Are women living with HIV better off when they're on their own with community and all of that? What's your sense as a well, you're a researcher as well, but as a clinician in the patients that you see day to day?
Yeah, well, I think Nora's study actually showed exactly what you're talking about. Francisco, I know you're controversial. I'm controversial too, so I don't mind controversy. I think we can't underplay the impact of gender and gender roles that have been, like, we live in a patriarchal society, and as women, there is a role that women have been given, which has for centuries been looking after the family, like not necessarily exercising, right? Being petite. So I think we underplay the impact of gender, and I think that as a society, with the Me Too movement, and all of us kind of pushing that the unacceptability of gender discrimination and that sort of gender stereotyping, I think that it is starting to change, like Shelley said, where women are exercising. And and I think there's two ways. I'm not sure, like the caregiving and like looking after other people is a component, but women who live alone have loneliness. Like loneliness is a big issue for women living alone, and and then for exercising, they would have to, as Shelley said, they want to make community. They have to go out and like find the resources, while someone with, like a woman with family and children, like they have the social support there, and they can potentially exercise with their children. Or I know women who have children, and it's the children who push them to go to the Y and exercise. So I think the stereotypes are a bigger issue. Culture. So Nora also spoke about culture in her presentation, I'm sure. But so I do agree actually with your controversial statement.
Thank you. You gave me that. Well, it's just from what I've seen, not that I, from being a researcher and an activist over the years. I want to pay attention to, before Kelly sends me like a zap and some kind of device, to the questions in the chat room. Kelly, could you, and then we'll invite Vladka as well to ask her question live. But Kelly, was a question regarding our colleagues from South Africa. Could you help me here with what was posed there?
Thanks, Francisco. Yeah, my question was just regarding some of the how Nora and Shelley and Naomi's programs and research resonate with our colleagues in South Africa, and whether there are any similarities and differences with their experience in engaging in community-based forms of exercise and rehabilitation. And so I know that there's been some comments in the chat, but welcome our colleagues if they want to unmute and maybe share some of their experiences.
Okay, who do we have from South Africa? Saul, I know you are...
Thanks.
Somewhere.
Thanks,
hello.
Francisco. Yeah, and Kelly, thank you for, firstly, well done, Nora and the Positively Dance group. Wonderful presentations. Thanks for organizing this, Francisco and others. So I'm currently in Toronto on sabbatical, so I'm kind of learning quite a bit more about what's happening in Canada. And there certainly are overlaps with the work that's been done here and work we've done in South Africa. I think, women the world over are facing a lot of the same challenges, kind of living in the patriarchal world. As Shelley said, that's no different in South Africa. We have a somewhat different pandemic in South Africa. It's very, very large number of people, over 8 million people living with HIV, more women living with HIV than men, actually. And as much as antiretrovirals have really helped, the treatment has improved dramatically in South Africa, but there's still a demographic in young women where you're actually seeing increased incidence of new infections. So it's a problem, and it's one that's with us for a long time. Some of the barriers are similar. Firstly, to focus on the positive, as Nora mentioned, some of the great positives that women have found from some of the exercise programs we've implemented in communities. But some of the similar challenges. The stigma is extremely significant in South Africa. It sadly still can mean, a death sentence effectively if someone is status becomes known. So we actually, we wouldn't, for example, have a website like, I looked up the Positive Dance website. It's wonderful, and that kind of thing. But we're not there in a case where we can openly say this is a intervention for women living with HIV or people living with HIV, and people will come then and join that kind of thing because of the very, very serious stigma. So we tend to talk about, programs for general health and exercise or rehabilitation in the community for anyone who can benefit. And that's the way we've managed to get our, research participants, and they've benefited. And what's been wonderful is because, people don't want to, for various reasons, very difficult to go far from where they live, but often women are setting up kind of groups within their community, just with neighbors and friends, So some of the things we've helped them with, they then just go with it, and we've heard great stories of them, setting up groups. Yeah, like I say, with friends and neighbors, not necessarily people living with HIV, but often also with HIV, and we've heard great positives from that, kind of physically and mentally, and so yeah, as I said and typed at the end of my response there, lots and lots of work to do, but we're very happy to partner with wonderful people in Canada and other countries. So thank you for the opportunity to speak.
Thank you very much. And of course, I would not be me if I didn't say, hey, now you go back there, you get money, and you invite all these girls, right? Women, I'm just saying girls in the friendly, invite them over. So they do the magic there. So thank you very much, Sol. Before we wrap up, I need to ask, there are a couple of people who have important questions. So one is Vladka and one is Verusia. Vladka, are you, hello?
Good morning from Vancouver.
From Vancouver. Tell us who you are and where you're sitting, which organization you're with, please.
Welcome to Dr. Peter Center, where we merge clinical, where we merge community and harm reduction. So, and I must say that I'm very thankful to you guys for also inspiring us to kind of look beyond the borders and boxes, and to adapt our fitness studio to make it more accessible to both women and men that come to the center. And I just would like to give a little update in regards to whatever I heard so far. And I'm sorry for being late. I was 2 hours stuck in traffic, left home at 4:30 in the morning to arrive at 9 to work. So, basically, what I find with the women that started engaging in the past year and a half in our program, it's first of all improved free time management. Basically, many of those ladies have chronic issues, and free time is a dangerous time. And in collaboration, primarily with me as a leader of this fitness program, but other staff, we encourage them greatly to use it better, which is happening. Also, I find very interesting that they're developing that health first attitude. So it's not anymore about antiretrovirals only, visits to the doctors, but also a chance for us to talk to them about diet, to talk about body image openly, to talk about something I called fear of stepping on a scale, which many ladies have, including myself. I would rather not, but sometimes I have to, just to monitor the progress. And then seeing that things are changing, that weight is more manageable, but also that there is a muscle mass improvement. Also, big thing is with these exercises for women and others, what we have, it's reported that women experience ability to manage anxiety from various aspects that HIV creates. Is it homelessness? Is it food issues, family issues, health issues, and anything like that? Pain management is improving, ability to find fitness body. Now we have a lady that has partner, and they're joining together and supporting each other. Also, ability for me to have an open door. So we are moving from stage of basic rehabilitation into a stage of independence participation, where I'm always available with advice or support if they need something, and to monitor how often they come, and there is some little hiccups in a process, and to encourage them to move on. Also to improve ability to openly engage with other staff in a center to take charge of own health. So instead of us constantly going after them and say, have you checked out with doctor so and so, I would say, well, how is going? Oh, I have a pain. So what's your plan? And they will kind of create their own plan that somehow they will take ownership of, and that ownership helps them actually take care of themselves better, or to see where the hiccups is and why, what happened.
Blanca, I want to ask you about the experience, because I know the Dr. Peter Center is also a harm reduction center. What is your experience, and maybe there's a question for everyone, of women who have lived experience using substances, including alcohol, polypharmacy, or other substances, and cannabis, and exercise? Do you notice, are there any major differences? Are there things that you do differently to support women in their movement, exercise?
Absolutely. Actually, I find that also awareness of negative effects of substances increases. So basically, it's also initiating their own effort, not just mentally, but also there is a bunch of different chemical reactions that physical exercise create and enhances, and the spiritual and emotional thing, like a sense of success if moving forward, that actually makes person think, well, maybe whatever I was doing, it's not so beneficial anymore, or it's not creating the effect that I was hoping for, since that exercise for me is better than, let's say, using marijuana or using something else. So I find in that process, within a harm reduction setting where we have services that which people can use to use substances, which are also monitored, helps us kind of educate people and lead by example and help them experience the positive effect of physical exercise. So it's sense. Kind of, that absolutely. Makes sense. Hey,
thank you. I wanted to go back to Nora and ask her on this note about whether use of substances came up in your interviews in any way. And by, again, I'm speaking broadly. Could be alcohol, it could be polypharmacy, those of us who take like a Tylenol with an Advil, with all of it at the same time. Did that come up in any way in your interviews?
May I ask Nora something else?
Oh yeah, give me just a second. Let's do that. Let's hear this. I want to join that with your conversation.
Sure. Yeah. So out of the women that we interviewed, only 2 of them claimed that they had previous drug and alcohol abuse. And exercise was seen as a mental health advocate for them. So in the past, they had dealt with this. They're recovering currently at the time of the interview. And when we talked about sort of their general attitudes toward exercise and the different benefits that they may have, mental health was the number one topic that we discussed, of how it helped them keep them on track and not to, fall down the path of engaging in, other toxic behaviors or behaviors that can be self-destructive, even smoking. So for them, exercise was not only important for things like looking better and, the physiological aspects of it, but more so the mental aspects of exercise were seen as the golden standard for women who, in my study at least, had suffered with drug or alcohol abuse at some point.
What I got from Blanca's question or update was that the idea that as those of us who may or not use substances, but through exercise became more aware. How does this resonate with you, Mona? And then I'll go to Naomi, whether this has been a consideration in your study as well.
I think clinically, I would say we under-ask about alcohol use. I think, other substance use illicit substance use, we tend to ask more about, like crystal meth and cocaine and opioids. But I think that there's more alcohol use among women than we know about. And so I actually, I think we need to, as clinicians, it would be wise if we asked more and addressed it more. We've started to do it in my clinic, and I find women will bring it up on their own. But I think I need to ask more about alcohol. Its relation to exercise. I agree with you. I think I haven't thought of it. I have AA books in my office, so anybody, and I try to do some alcohol reduction brief therapy, but I haven't tried yet the idea of saying let's incorporate exercise as a means to increase your dopamine and levels instead of the alcohol. So I might try that. So thanks for that, for a good idea.
Well, thank you. I'm glad there's a little morsel for everyone. Naomi, very quickly, I'll pass on the same question to you briefly. So we go to one last question, then we'll wrap up. Same idea. Have you noticed any relationship between exercise, women living with HIV, and any substance use, and whether they become more aware? Maybe that's a form of therapy of some sort.
Yeah, I think Shelley probably might be able to answer this more accurately than I can, because she's there on a regular basis at the dance classes. I think we are probably not attracting the group of women who may be also actively using, so it's difficult to say. And I think the reason for that is because, and something we're trying to unpack constantly, the barriers that we've set in terms of enrolling into the study and the level of commitment we've asked, and the requirements for using technology such as surveys and stuff like that. So these are things that I think are barriers, and so we may not be able to meet. I don't think we've reached, for example, women who are actively using, or who may be precariously housed, or who experience all sorts of structural violence. And so yeah, I think that's an issue with the way we've kind of that's some of the issues, I think, with research specifically, and when we spoke to how rigid methodology can be a barrier in and of itself. I think that's what we were talking about specifically. And so as we unpack that further, and which is why we took the randomization out of it, because it was so unfeasible. Ultimately, it was very unfeasible in the way that we were conceiving of this project, for it to be very inclusive and accessible to folks. And so as we unpack, and as things come up and we unpack how, in the ways in which we design the study and the ways in which it may be posing barriers, then we try to dismantle those and try to make it more accessible. But from a more pragmatic perspective, the dance studio also has pretty strict guidelines around substance use, aka a zero tolerance policy. So we haven't really confronted that. We do talk about it with participants when we do the initial interview or screening questionnaire with them. But in my personal experience, that hasn't really come up as a tangible, kind of as a salient conversation. Although it has come up a little bit, but not in a way that I would say really has been highlighted.
Now you're starting to think about it. Now some sentences. Well, Shelley, very quickly, in relation to this, what's your opinion? Because one of the things I'm thinking, I'm not even thinking about the big drugs, illicit drugs, as Mona mentioned. I'm thinking about some of us who use weed and exercise, right? And which may or may not be, I don't have research on that in front of me, but may be fairly common.
Well, I'll just say, and I'll actually, Naomi put it quite succinctly, because there's a zero tolerance policy at the space, that has also, helped in terms of that being an issue, in terms of we've never had anyone come in that we've had to deny access. But that said, there are definitely women that are in active using, not in the moment at that time, but they're certainly either on a methadone program, or they're in harm reduction model, or they're smoking cannabis as soon as they walk out the door. And all of that it is part of We are trusting women to come into the space prepared to dance. And so with that trust comes, I think it allows for women to feel a little bit safer. And the ones that like Naomi says, they haven't come yet. And it is a huge commitment, twice a week, even for anybody to make a twice a week commitment to go to a dance class is a big deal. So, and because of the times, it's helped. But yes, we've had these conversations, and we've actually anticipated problems that didn't happen. So that's good news.
Good. And of course, I don't want to create these questions create the idea that substance users are only substance users, right? And we have substance users who do all kinds of things, including being in the movies or being musicians or being air pilots, right?
Including cigarettes, and
including cigarettes. Yeah. I mean, we do have our brothers and sisters who, and I guilty as charged, who would come out of the gym and it's part of the addiction. Folks, before we close down, we must remind you that we need your evaluations because it makes us get better. So I think Kelly or Kira are going to place that in the chat room. I want to know if Virusha Chetty is still online. You had a question or a comment that we still have time to take. Are you around?
Francisco, Virusha had to leave. She messaged me. It's late back in South Africa, and she had family things to get on with. Yeah,
they were there. Okay,
but she really appreciated the talk and thanked everyone for great work.
No problem. Thank you. So before we close down with we go to your final remarks, all of you in the panel, in relation to women and exercise today, women living with HIV and exercise today. I want to ask Kira or Kelly whether there's one thing that I've missed that is super important that we should have asked this lovely folk.
No, I don't have anything to add. You did a great job. Thank you so much, everybody, for the panel discussion. It was really engaging.
Kira, you look like Kelly, but maybe that's just me. It's, my eyes are not what they used to be. And so, folks, let's start. I have you all in small squares. So let's start with you, Joanne, if you don't mind. Do you have any parting words? I mean, there's tons more to say. There's tons more research that we need programs as opposed to closing them down, which continues to happen. What would be your parting words to our audience today and the members of the panel?
So the parting word that I have, Francisco, is exercise and movement are life-saving devices. And I remember somebody even saying to me one time about how, wonderful it was that I went to the gym. And I just looked back at her and said, but I have to. It's part of my longevity program. It's a life-saving device for me, and it's so easy to forget. It's so easy to let barriers get in the way, and to even just emotional barriers, not even financial or physical or other things, but emotional barriers can be crippling. So exercise is a life-saving device. That's the word I'm going to share with other positive women that I see regularly.
Thank you, Joanne. And we're truly and sincerely happy you're with us and continuing stamina and emotional energy to you. Naomi, let me go to you and for some parting words, please.
Yeah, I'll work off what Joanne said, and when Shelley mentioned, how can we move away from thinking of exercise as a luxury? And I always like to think about exercise not as medicine. I don't actually really like this idea of exercise as medicine because I think it really pathologizes not exercising. But what I really want to shift towards is exercise is joy, right? This thing that everybody's inherently should have access to, and that even if you are living with HIV or experiencing this or experiencing precarious housing, you have an inherent right to these things, and you have inherent right to be, you know, pursuing joy, and exercise can be a source of joy. So I think, yeah, that's a beautiful thing.
Thank you, Naomi. Much appreciated. I'll go to you, Nora, for your final thoughts today.
There's so much to be said that unfortunately 2 hours is not enough. But what I like to say, piggybacking off Joanne and Naomi, is something that one of my study participants informed me at the end of the interview, which is you can never overemphasize the importance of exercise. And while we all generally know the benefits of it, when speaking with our study participants, I realized that they just know sort of the general idea of how exercise can help, but not necessarily the in-depth knowledge. And so hopefully we can incorporate more community-based, you know, classes, groups, provide more educational resources like, you know, pamphlets and videos, perhaps from the clinician's point of view. So I think, as my study participant told me, you can never, you know, overemphasize the importance of exercise. And I think she said it the best in that one clear sentence, so that I would pass that on to everyone else joining us today.
Thank you, Nora, and thanks for again putting up with me through your video making and all of that. You're a star in the making. Mona, I go to you, and again, thanks for joining us. I know you're in clinic, for your parting words today.
Oh, thanks so much for having me. I'm glad I could make it. I think Joanne, you know, said it the best. And after hearing Naomi, I feel so bad, like being a doctor. I'm like a pathologizer because I think exercise is joy, but I do also think it's medicine. So that's, you know, what I want to say is that it, you know, it is for joy, but it also has been shown, as Joanne said, to, you know, correlate with longevity. And from an exercise standpoint, the one thing I would stress is cross training. So like doing the weights and resistance training, like whether it's with weights or bands, as well as the cardio with the movement or dance, walking, swimming, biking, all, like, both are important. So I don't know if we went into that in too much detail, but I think cross training is really important. Thanks.
Thank you, Mona. And last not least, as we say, Shelley, please, I mean, and again, it's been a pleasure to reconnect on this. We will invite you again, so you do like an extended long play presentation on what's coming up in your research. And I know you extended to March 2023, so good for you. What are your parting words?
Well, amazing presentations and amazing. Thank you all for staying and listening this long. I'm going to have to quote my mentor of all dance mothers that I've ever known, which is Martha Graham. And I'll just quote her. And she says, "Nobody cares if you can dance well. Nobody cares if you can't dance well. Just get up and dance. Great dancers are great because of their passion." And I think that applies to exercise and movement and joy. And if we can find something that motivates us, that gets us to a space where we can share movement and work, and for dance isometrically, I don't think there's a better form of movement than that. And I highly want to agree with Mona as well about cross training, and also Joanne. You know, there are limitations that the body ultimately dictates. And another quote from Martha Graham: "The body never lies. The body always tells the truth." So the body will tell you what you're capable of, and pay attention, because our bodies deceive us when we least expect it. And when we just engage and we trust the spine and the head and the emotions and the movement and the intention, we can create amazing things. And it doesn't matter what body we live in. What matters is how we live in it. So thank you so much. It was an amazing presentation. Thank you so much, Francisco, for your mentorship back in the day as well. And Mona, you missed the presentation, but you were instrumental in where this idea came from. It came out of groups out of CIHRRC. So thank you so much.
Thank you. Thank you. So now, before we close down, I remind you there is a link to the evaluation on the chat room. We're going to send you the link again. Please give us it's not a long survey. And certainly we will not ask you if you're exercising or anything like that. It's just about the actual event. Now I'm going to call up our fierce leader, Dr. Kelly O'Brien, who has just one more update, and then we close the session for all of us. Where are you, Kelly?
I'm here. Thanks, Francisco. I want to thank all of the panelists, Naomi, Shelley, Nora, Mona, Joanne, and Francisco, you for your leadership with these community of practice sessions. I have shared my screen. Can you see it there? Maybe not.
Yes, we can. Sorry,
okay,
I was
perfect. Muted. Okay. So one of the things we've been working on behind the scenes is a website, and I've just put in the chat box here the link to hivinmotion.ca. And this is a new website, and we have to sort of really thank and hats off to collaborator Patrick Gale from the Gay Men's Health Collective in the UK, who has been a collaborator of over 10 years with Francisco and I and others with the Canada International HIV and Rehabilitation Research Collaborative, or CIHRRC for short. So the HIV in Motion website is freely accessible to all. But one of the things that I wanted to highlight today is if you go to the link videos under knowledge translation here, you can see all of the links from these community of practice sessions. And this was the 8th one that Francisco has hosted and led since we started the HIV in Motion study back in spring of 2020. And so all of the links to the videos and any fact sheets or outcomes or products that come from past sessions are there. So feel free to explore those videos. So for example, in May, Dr. Tiz Giancarlo did a session on fitness trackers and wearables, which was an excellent session. We had a physiotherapist from the UK and a panelist talking about group-based forms of exercise, for example. So that's all I wanted to do, was just sort of share with you today. And I will stop sharing, figure out how to, yes, okay. There we go. And then lastly, just wanted to, of course, acknowledge the Canadian Institutes of Health Research, or CIHR, which funds the HIV in Motion study, which supports this community of practice, which is an integrated form of knowledge translation throughout. And then alongside, in tandem, we have the HIV in Motion research study, of which involves a large team of researchers, clinicians, community members, and ambassadors of HIV in Motion who've been involved not only in the research, but also in planning these sessions today. So thanks to everyone. Thanks to Patrick for all your work on the website and behind the scenes. And lastly, thanks to Francisco for your fierce leadership in this work. So back over to you.
No problem. Folks, I remind you once again that we're super happy that yesterday, and I'm saying this to all the researchers who understand this, the struggle, the exercise of getting another grant. We just got another grant on chronic pain and living with HIV. All these things feed into each other. So we'll know more about these things. So we thank you all. Have a great day. We'll keep in touch with us, send us ideas, send us your complaints, your rants, your love, everything via email. Visit our website, and we'll see you in the next HIV in Motion event. Have a great day. Bye.
Thank you, Francisco.
Bye, everyone.
Bye-bye.
Thank you.
Bye. Thank you.
Bye, folks.
Thank you.
Bye, everyone. Thank you very much.
Thank you, everyone.